to have this discussion. So yes, we wanted to discuss chronic venous ulceration and diabetic foot ulceration, two very common problems which are growing in magnitude in this country. And yeah, so we thought it would be most appropriate to discuss this amongst us. And you're most welcome to send questions, and we will try to answer at the end of the session. Yeah. So in both situations, ulceration, which brings me to the point about wound healing. As you know, healing is a natural process, and biology does it. We go through the 4 stages: hemostasis, inflammation, proliferation, and remodeling. And there is some overlap, but there is a gradual progression towards complete healing, which is very natural. Now, in the situation of certain comorbidities, the healing process gets stuck at inflammation, proliferation point, because there is ongoing little injury, and there is the body's response to inflammation, and the proliferation really doesn't overcome the injury, and the wound is then non-healing. So in both situations, in venous disease and diabetes, that is what happens. Of course, there are common reasons as well as unique reasons, particularly with the diabetes and neuropathy. And ischemia is common to both, which keeps the healing process stuck for long periods. So here we are going to discuss how we can liberate our patients' healing processes and get wounds to heal. So let's start off with chronic venous insufficiency and ulceration. And here we see something very familiar to all. Nalaka, would you like to start off by just saying why we have varicose veins and so what?
Yeah, so varicose veins is quite common, as you know. Usually it's said that over the age of 40, almost 1/3 of the population will have varicose veins. And doesn't necessarily mean that it's only the ones who are above 40, when younger people can have. But the take-home message is that varicose veins are quite common. But the flip side of that is, just because you see varicose veins, you don't really need to do anything, and patients also don't need to seek any treatment, because the vast majority of varicose veins are actually asymptomatic and harmless. But the ones, for example, like in this picture, they are obviously going to be symptomatic. Apart from the cosmetic disfiguration, they will always have some degree of heaviness, pain, especially on standing, and the rare complications of phlebitis and spontaneous bleeding and eventually ulceration. So in that instance, yes, definitely you need intervention. So the important thing about varicose veins, as I said, is that varicose veins are common, very common in fact, but the vast majority do not need treatment unless the patient has a cosmetic issue. You just need a proper assessment and reassurance. But if they do have symptoms which are very likely to be due to varicose veins, then yes, it needs assessment in terms of a Doppler scan or duplex scan, and intervention in terms of either thermal ablation with laser or RFA, or foam ablation or sclerotherapy. We'll probably discuss those in the next few slides.
Yeah, quite true. I mean, it's more the fear of the unknown, because it's something that is visible. None of us people are too bothered about what is invisible. Heart disease, diabetes, invisible. Varicose veins, you can see it, you can feel it, and it's really frightening. So let's move to a case. I wonder, we'll go with Aruna. are going to tell us about a 65-year-old man has had pain in his left leg, outer thigh and buttock that increases on standing and walking for 8 months. Takes paracetamol when the pain is severe, been to rheumatology because of the pain. And the rheumatology medical officer has spotted varicose veins and given tablets and compression stopping. He was feeling a little better with the treatment, but the patient was referred to you for treatment of his varicose. So what are your thoughts and what would you do?
Actually, I analyze his symptoms of this patient. So he's basically is quite old, he's 65, and his symptoms are the pain in the buttock and the lateral of the thigh. And he just has been there for 6 months. So just recent onset pain. So usually these varicose veins related pains are dependent, and as in this patient is true, but particularly the pain is very different. So pain is usually around the calf area, and so you should get relief while the patient is keeping a leg up. So, and then the other thing is mere presence of varicose vein doesn't mean that its pain is mostly related to the varicose veins. So you have to go in and check again and see examination, so whether the patient has got any straight leg is positive in this patient. So I would really doubt whether it's really due to varicose veins causing the trouble.
Very true. It's clearly you can't have buttock pain from varicose veins. That would be very strange. I mean, most of the time the pain syndromes are not very clear as to what's causing it, and you attribute it to the varicose veins. But in this instance, you have either clear osteoarthritic knee pain, plantar fasciitis, in this case, lumbar nerve root compression, which needs proper evaluation because treatment of varicose veins is not going to relieve symptoms. And in the 65-year-old man, is not too bothered about his veins. So that's a very common referral we get, and we need to deal with this on a rational basis. And we'll go through, we wanted to do case-based discussion. So let's go. 50-year-old, varicose veins, swelling and ulceration, very common combination. So let's get a few more details. Duration, 15 years of varicose vein, 3 years skin changes, and leg swelling, 6 months of ulceration. Ranjuka, what are your thoughts and what would you recommend in this situation?
Yeah, this looks like a patient who has had varicose veins for a long time, and gradually and with time it has got complicated because of the venous hypertension and eventually ulcerated. And the picture shows a characteristic venous ulcer with nice red granulation tissue, sloping edges, healing edges, and with surrounding evidence of lipodermatosclerosis because of the venous hypertension. So the way I would set about is probably start him with strapping, ideally like a 4-layer strapping or a strapping which gives a pressure of about 30 millimeters mercury with a dressing on top of this, maybe a foam dressing because it looks like a quite a wet kind of oozing ulcer. So we will maybe weekly compression, and at the same time I will assess his venous pathology with duplex scan and see exactly what the problem is, and see whether it's a long saphenous territory. Generally, this looks like a long saphenous. That's saphenofemoral incompetence, long saphenous vein reflux, and varicose veins. So we now know that we have to treat this with the strapping as well as treat the underlying cause of the venous pathology. So I would, if it's with the duplex, really mark everything exactly, which is refluxing, what's the size of the long saphenous, where are the varicose veins, and we will give a customized plan like the long saphenous treated with either RFA or or most commonly endovenous laser. And depending on the varicosities, with if they're very large, we would go for multiple stab avulsions of lobectomies. Or if they are small, we can we if they are small, we can do duplex guided foam stereotherapy. So basically, strap and treat the underlying cause.
Right, Ranjaka. Thanks. Uh, so just to summarize, rather than getting into the management itself, this looks like primary superficial venous reflux, giving over a long period, giving rise to the dreaded complication, ulceration. So you deal with the varicose veins, and as you said, we should have a good result. We'll move on to the same patient, which you did. If this patient did have these additional features, diabetes, being a smoker, he's had coronary revascularization a couple of times, the stents and then cabbage. He's also claudicating. A Nalaka, then we would be having an additional problem, which we are seeing increasingly as our population ages.
Yeah, true. I mean, that's a common clinical scenario we get nowadays. You don't really get straightforward venous ulcer without any other comorbidities. So in this instance, just going by the history and the varicose veins and the clinically very suggestive ulcer of venous type of ulcer, diabetes will not have any direct impact on it. Obviously, we need to control the sugar, but other than that, two things going by this history in the slide. One thing is that he's a claudicant, so I'd like to check his pulses, disturb pulses before I start strapping. And also the fact that he's had a CABG, I'd like to see whether the vein was taken on that side. If the grace evidence vein has been taken or harvested on that side, I might have to actually look at the short circumference part as well as the deep vein reflux just to exclude any previous deep venous issue.
So, yeah, as you say, it's not just the venous reflux here. Even a mild ischemia would complicate, as you said, the compression. People don't tolerate compression in the presence of arterial occlusive disease. The pain could get worse. Ulcer could actually get worse from compression and worsening ischemia. So we need to deal with both pathology, and depending on the severity, we might be able to heal it without arterial interventions. So how do we generally assess the severity of the arterial occlusive disease?
Yeah, so to start off with, as I said earlier, it's very important, even though the clinical picture is very suggestive of venous disease, just to check the pulses and see whether the pulse is present or not before you embark on a multi-layer strapping. And this particular slide shows it very well, because this particular patient doesn't have pulses popliteal downwards on the affected leg. So the initial simplest assessment, as I said, is the clinical assessment of absent pulses compared to the other leg. So then you know there is a problem. Then to quantify it or put some kind of number to get an idea about the severity, you can do what's called an ankle brachial pressure index, and it will be done in this patient 0.7, which is not terribly bad, but it's still less, it's still low. So that's basically you compare your tibial pressures as opposed to your brachial pressure on the ipsilateral side. And generally, a normal person would have 0.91 or sometimes even 1.1 in that range. Anything below 0.7 is significant ischemia, significant problem with their blood flow. So this particular patient has also had an angiogram, as you can see. So flow of very little flow below the mid thigh level downwards. So this patient, as apart from the external appearance of venous ulcer, he's got a bigger issue. So I will be very reluctant to just put him on strapping. I think we might definitely need to look at this underlying ischemia component. Might need correction even before we do anything for the venous ulcer.
Yeah,
Can I just, sir, can I just, I mean, the picture that you have put, I mean, we had just to add one comment, you know, that the venous ulcer, which is here, looks very straightforward, it doesn't look ischemic at all. But when there is a combination of ischemia, generally the granulation tissue is not this red. It may, you might have, something like this, yellowish. Yeah, and yeah, something like that. So that picture looks like a straightforward venous disease to me, but the next one looks like more like a evidence of diabetes, amputations. That's more like which suits this one. So I think the message should be, if you see something like this, always before you strap, you have to check the pulses. You suspect the arterial injury when the tendons are exposed, when the color is not red, when it's more yellowish, and when it's more dry, it's not oozing, but it's dry, it's more desiccated. And so that gives the picture of a combined venous arterial ulcer. I think otherwise the listeners might go away thinking that this sort of thing is a pulseless limb. That picture suggests a very vascularized venous ulcer with normal arterial one. But your next picture shows something like a dual pathology.
Yeah, so yes, in this instance, pulse is absent and the ABPI is such that you're not looking at severe ischemia. It's a chlorine content. It's compatible with.
Yeah.
And I think what you said is true. Before applying compression, as a rule, we vascular surgeons don't do anything in the extremity without checking the pulse. We don't operate, we don't apply compression without knowing what the arterial perfusion is. And in this instance, as you say, we might be able to apply milder compression, maybe a little bit of interest, which we usually don't go by, but go on compression. And the ulcer might heal. It's clean and it's red.
Yeah.
And the arterial ischemia may not be playing a major role in the non-heal. But the next picture, obviously, is a man, Aruna.
Yes.
Very clearly
see the
arteriopath with an amputation.
Yes. Victor is already missing and some of the toes are also missing. So you can see the scarring in the ankle area. So the hair color, as Pranjal said, is really very unhealthy. Granulation tissue is not showing any evidence of healing at all. And then, so this is a typical arteriopath. Typically, maybe having mixed venous disease, not only arterial and venous disease both.
Yeah. So if the arterial disease is precluding healing, then we would have to intervene, revascularize, at the same time deal with the veins. So another case scenario, say the same, the background is 50-year-old varicose vein swelling and ulceration, and here is the history here. Aruna, what do you make out of this?
So the history says 50-year-old varicose veins and swelling ulceration. So this looks really the same picture.
No, it's the history that we are interested in.
So this is just 15 years of leg swelling and skin changes over 5 years. So this is a chronic venous disease which has been going on for duration. And recent onset ulceration. So very
recent varicose veins.
Yeah, all right. So this is something unusual. Usually, for you to get.
So what it's different to the case scenarios that we had now. You got varicose veins recently, but he's had leg swelling and skin changes preceding that.
So this, I would think.
What would you be thinking?
Where there is something underlying other than the near
deep venous reflux.
Deep venous reflux, yes. So, or maybe deep venous obstruction due to previous DVT.
So, what do you think Naraka could have been? Because people don't come and say, some of them are never aware that they had deep venous thrombosis. Some people have known it, but they've forgotten about it. And
Yes, I mean, that history is very suggestive of a prior deep venous issue. Like Prof said, most people don't even know that they were DVT. As you know, it's underdiagnosed in this part of the world. Even if it's diagnosed, inadequately treated, and so on and so forth. So very likely to be DVT. And the subsequent part of the history of femoral fracture 15 years ago, chickenpox 20 years ago. So could have been anything. Patient would have been bedbound with the fracture or with the chickenpox. Immobilization very often is due to fractures and plaster cast and external fixators being inserted when they were young. And they don't even know, but that immobility causes deep venous disease, deep venous thrombosis, DVT. And later on, that leads to deep venous reflux. So that's why the chronic leg swelling precedes the varicose veins. The varicose veins are secondary then to the DVT. So the natural progression is that you have an injury like a orthopedic injury, you get immobilized, you get DVT with immobilization, diagnosed or very often undiagnosed, and from that point onwards, you get chronic venous insufficiency, deep venous reflux, and secondary varicose veins. This venous duplex also suggests the same common iliac vein defect seen. So I still got evidence of DVT in the common iliac vein.
yeah, definitely. So let's move on to managing these patients. Obviously, you have the wound. I don't think we will spend time dealing with wound care in this webinar. Debridement, primary dressings, local antimicrobials, and that we will leave for now. The question is, how do we manage the venous stasis? Nalika, would you like to
So
go through how we deal with venous stasis?
Yeah, so venous stasis and ulceration, the treatment or the management of the patient would depend on managing the ulcer as well as managing the underlying venous disease. And the previous case, either deep venous disease or prior to that, a simple superficial venous reflux. So regardless of what the underlying venous pathology is, if it's a definite venous ulcer and pulses are palpable and there is no evidence of distal ischemia, then the primary component in the management is compression. Compression with ideally multi-layer compression, and that has to be a long-term. It has to be a long-term thing. It's not going to be a one-off thing where you compress for a week or a month. It's very likely to take 3 months, 6 months at very frequent intervals. So compression is the mainstay. And with the compression, regular wound dressing, wound care, rarely even wound debridement or wound scraping may be needed, but it's rare. Antibiotics usually are not recommended or not required because the majority of these venous ulcers are fairly clean and not infected, and just giving an antibiotic on a surface swab is not going to achieve much. So, like I said earlier, it's compression. Compression is the mainstay. Regular compression, multi-layer compression.
And venous stasis.
Yeah, for the venous stasis part, so if it's superficial reflux, then it's easy. Previously, of course, with the Eschkatra, we were told that whenever there is an ulcer, so we'll discuss that. But so superficial venous reflux eventually will need correction with either surgery or thermal ablation. Deep venous reflux, well, generally you don't really have any surgical options for deep venous reflux, any lasting surgical options. Theoretically, yes, there is deep vein reconstruction and valve reconstruction, which hasn't really proven any long-term beneficial effects. If there is a past history of DVT and secondary varicose veins with simple deep vein reflux and no deep vein obstruction, no deep vein occlusion, then you can still treat the varicose veins, superficial varicose veins. I'm sure Prof will come to that in a different slide because that's a very specific area. But generally, to remember it, what you need to understand is if you have a venous ulcer, you need to treat the venous ulcer as well as the underlying cause, which is either the superficial veins or the deep veins. If it's superficial veins, superficial venous reflux, then the treatment is very straightforward. You can do a thermal ablation or surgery or foam, whatever, get rid of the superficial vein and very likely you're going to achieve a lasting solution. If it's a deep venous disease, then it's not very straightforward. It's a little bit more complicated. Then you need to specifically look at the deep veins and see whether there is deep vein obstruction or deep vein reflux. Deep vein reflux only without obstruction, then you can still treat the very superficial veins. If it's deep vein obstruction, still persistent deep vein obstruction, then likely the patient will require long-term compression.
Right. So that's the principle behind the way we manage. Just how we actually evaluate these patients. Arun, is there any? We'll ask Ranjika. Clinical evaluation. I mean, how useful is it? How much information does it give apart from saying we can see varicose veins and skin changes? But how good is clinical evaluation for superficial reflux, deep reflux, occlusions, and so on?
Actually, clinically on examination, it's you barely. It's not really great for, I would say, nowadays to do tourniquet tests and all that basic stuff that we describe in textbooks. So in the practical sense, we do not really examine, do tap tests or check reflux. I mean, now all the vascular surgeons at most centers in Sri Lanka we have duplex scans. So I think duplex scan gives a better exact understanding of the venous pathology that a patient has. So I would say clinical examination has a little place nowadays, but we would like always stick to basics. Look at the ulcer, look at the surrounding tissues, look at the basics of the ulcer, then look at the distribution of varicose veins. We palpate them for fascial defects, look at the perforators, but you get a better understanding and exact view of what the patient is having with the duplex scan. It's like seeing into you and getting a map of the problem that you have with the duplex scan. So clinical examination as a little place.
Yeah, well, I agree that, duplex scans, because we have access to duplex scans, we have kind of abandoned relying on clinical evaluation. Say the Trendelenburg test. I see a lot of students doing these tap tests, which I really don't understand why they do it. We don't do Perthes tests, get it, put it turnkey and get people to walk for pain and so on, but commonly the turnkey test. And I think if you're working in a periphery without, most surgeons might have to get an appointment to get a duplex scan. Patients have to come back. There is a delay, waiting time. Sometimes you think, okay, you would go back to clinical features, look for a saphenobarics, there is a CEPHI, the Trendelenburg, the tourniquet test will tell you, hey, it is highly likely that the trunk, the saphenofemoral junction and the trunk is refluxing. And then I'm telling you because I did work before the duplex era. And what we did at that time, we just did a saphenofemoral truncal ablation and marked the veins and either stabilized or gave injection. So you get it right a fair number of times, really. But if you're going to inject each one of these veins and so on, still again you inject what you see. But we have got used to duplex, and that's what it is.
Yes. It's a clinical evaluation. So sometimes we tend to miss the importance of checking the foot and the carpal pump activity in terms of venous return. So if somebody is having a fixation to the ankle due to previous scarring, maybe it's an orthopedic fracture and some kind of issue. So then the foot and the half muscle pump doesn't work. In that sense, there is definitely going to be a deep venous reflux. In the sense, a stasis due to deep venous incompetence. So I would think that that's involved.
Yeah.
Most of the time we miss that.
Yes, the stiff ankle, the calf muscle pump failure is common. So all you need to do is then, you need to give physio and it's going and apply compression to counter the muscle pump failure. Now, like venography, contrast venography, IVUS now, ultrasound, intravenous, where are we?
Very limited place. I won't say there is no place, there is very limited space. In routine clinical practice, no. We do even here in Sri Lanka, we do venography on selected patients, not for simple varicose like this, but if we have things like triple Tremonti syndrome, for example, which is a very rare condition, but if you see things something like that, or if you're having acute PVT, or if you want to exclude recurrent ulceration where you can't really explain and then you want to rule out something called May-Turner syndrome, that kind of thing, yes, we do venography, but by and large, I think venography is out. It's not a routine test. It's going to be primarily clinical evaluation and duplex scan.
Yeah. So yes, venography and more recently IVUS has come into play because of there is evidence coming out that lots of venous problems are due to compression of the common iliac vein origin from the overlying artery and maybe some other factors like even intra-abdominal pressure. And these are increasingly treated with stents. And to put a stent, you need to confirm that there is a stenosis, and that's making people do venography and IVUS, particularly in the US, not much in Europe. We haven't really got onto that as yet. So coming on to how we actually ablate the veins. I know you touched on it previously. We have surgery, heat, and chemical. So would you like to just run through I've drawn the main veins that we would be studying on duplex and how these would be applicable to ablating veins, varicose veins originating from incompetent valves in these systems.
Yeah, so superficial venous reflux, simple varicose veins. I generally like to categorize them as junctional, truncal, and non-truncal reflux. So that's a very broad categorization. Junctional means SF junction and SP junction. Truncal means the main trunks, the great sepinous vein trunk and the short sepinous vein trunk. And the non-truncal ones are the in-between varicose veins and the branches, tributaries, and so on. Generally, when you're talking about the main varicose and the SF incompetence or SP incompetence, and therefore great sepinous vein reflux, the age-old technique or the management option was surgery, surgical stripping, SF ligation and stripping of the great sepinous vein down to the below-knee area. Now, I would say over the last 20 years, it's gone relatively out of practice. I know it's still practiced in most centers outside Colombo and outside the main teaching hospitals, but still, I think more and more people are moving away from it due to various obvious advantages of non-surgical, the so-called non-surgical techniques. The non-surgical ablating techniques, again, ablation is a word we use. Ablation generally means destroying the affected vein. So this ablation or destruction of the vein can be achieved by simply two methods. One is thermal ablation, where you use heat energy. Then this heat energy can also be broadly given in two ways, either laser or radio frequency, both of which we have fairly openly used even in Sri Lanka and basically all over the world. It's almost like the gold standard nowadays when you want to do varicose vein ablation, you use heat energy, that is thermal ablation, with either radio frequency or endovenous laser. The other method is non-thermal, where you use not heat, but you use chemicals. So these chemicals, you can use either foam, which is the easiest and the cheapest. And then there are other things like cyanoacrylate glue, which is again used in other countries. But so broadly categorized, how we would treat varicose veins is that. So you will still have a place for surgery, especially when the expertise and the equipment is not available for non-surgical ablation. But if this expertise and the appliances are available, then I would say the gold standard is thermal ablation still, which is either with endovenous laser or radio frequency. And for other selected patients, for example, very old patients or people who don't tolerate thermal ablation, you can always use chemical ablation with foam, liquid or foam. There is STD or fibroven, which is another type of ablative chemical, so you can use foam ablation.
I saw a hand up. Was there a question or a comment?
Were there any questions?
There's a hand up. Okay. Right. So we have some randomized clinical trial evidence comparing surgical stripping versus laser and foam. What have they taught us? Is there anything that is superior, better, something that is ineffective, we should, basically abandon using, or how does it go now?
Well,
Pre-Erasmus study and the class trial.
Yeah, if you look at the trials, actually, as I said earlier, ablation is the destruction of the vein. So, in terms of the success of destroying the affected vein, there's hardly any difference between thermal ablation, that is radio frequency, laser, or surgery with recurrence rates only about 2% at 5 years, if I'm not mistaken, something like that. So, anyway, successful ablation is about 95% or thereabout in all these techniques. Foam ablation is slightly less, it's about 85%. So, statistically, it is significantly less, but nevertheless, 85% success rate is fairly good for a technique like foam ablation. So, those are the statistics, and those are what the trials have shown. Surgery, and apart from obviously the actual effectiveness or efficacy of ablating, you also need to consider the other factors like quality of life afterwards, the pain, post-operative pain, the requirement of staying in hospital or bed rest, time taken to go back to pre-operative mobility, and so on and so forth. So when you consider everything, all of that, still, as I said earlier, if the expertise is available, thermal ablation is considered better. That's what most of the guidelines, including the NICE guidelines as well as the American SVS guidelines, have recommended that they had equal ablative success rates to surgery with less pain and earlier mobility, earlier ambulation compared to surgery. Foam ablation is effective. Efficacy rates are significantly less than endovenous laser and thermal ablation, and as well as to surgery, but still, as I mentioned earlier, about 85% ablation rate at 2 years. So those are the techniques available. If you ask me personally, I think thermal ablation with endovenous laser is definitely the gold standard.
If I just add something, now look at this is done. Surgery is done under regional anesthesia, and this is done under tumor set anesthesia. So it takes off most of the complications of a spinal, and even the DVT risk is lot less So, although the recurrence is the same, but lots of advantages with thermal ablation. So, I think the future will probably surgery will be reserved for only a few very large ones or venous aneurysms kind of ones and very large, more than 2 centimeter trunks and junctions and dilatations more than 2 centimeters in the main trunk. Other than that, I think mostly everything can be ablated with thermal ablation. Just to add.
Absolutely. I think two things that those trials didn't show. One thing is, yeah, you're absolutely correct about the need for anesthesia in surgery. And the second thing is the requirement for a groin incision, which was never really tested. I mean,
yeah.
All of us know groin incisions are not easy. Even when you have taken all precautions, groin incisions can become nasty infections. I mean, it can get infected very badly and limit your mobility and cause a fair amount of morbidity. So if you can avoid that, so much the better.
Yeah, then the typical surgeon talking. Definitely all these endovenous techniques have basically got rid of, well, the bad surgeon managed to escape, isn't it, Malika? I mean, good surgeon doesn't have, except in very obese people, yeah, those are really the ideal ones for endovenous. But looking at this country, I mean, lots of thin people with varicose veins in the periphery, and the surgeon doesn't have, mind you, the laser fiber. What's the cost of the fiber now? It's about 150,000.
It's more than that. It's about 200.
It's about 200,000 rupees used on 5 instances. So it's about 40,000 rupees per patient. I mean, it's in dollars. You can't buy it in rupees. So I think the periphery still, if you want to, treat your patients and they don't want to go out of the area, the district for the varicose veins, surgery still offers quite a good deal. I mean, laser needs an ultrasound as well and ultrasound skills. So some of our general surgery colleagues might still be able to offer patients who don't mind surgery with quite a good outcome. So I think that's how things go. I generally recommend foam for people beyond, say, definitely beyond the age of 55 or 60, because none of the trials showed that quality of life was any different, whichever method you use. And varicose veins are anyway a benign condition, and any recurrence that is causing any problem can easily be retreated. And even if it recurs after surgery or laser, we finally end up giving injections for recurrent varicose veins. So there are people who, there are colleagues, especially Malay Patel. I mean, he uses only foam for everything, and he says, I just reform if the necessity comes. It's dirt cheap. It's done in the outpatient room, and there's no admission. Sometimes you think, unless the patient is willing to buy his laser fiber, it may not be even should be offering these. So those are any practical ways of doing things, thoughts. Moving on. Ranjuka, are you? Do you remember 2 trials? Timing?
Yes.
Right. Yeah. Just summarize the message from trials.
Yeah. ESCA actually looked at surgery with ulceration, and at that time mostly operative surgery, and that showed it did not help healing, but it reduced the recurrence of ulceration. So when the ESCA results came, we did surgery. When there was ulcer, we used strapping, healed the ulcer, and then we did ablated the or did operations on the superficial veins to reduce the recurrence of ulceration. But then came EVRA, which actually in that study, about 500 patients, I think, it used laser, foam, minimally invasive techniques, and that showed the healing rates were almost doubled. The rates were faster. So, so then actually our usual practice changed after Debra, because with the minimal invasive techniques of thermal ablation, and in that group, the most were actually foam ablations. So even with foam ablations, the healing rate was faster, significantly, almost doubled, if I remember right, than the usual time taken for a ulcer to heal. So I think this Evra showed us that if you have ulcer, treating the underlying venous pathology with minimal invasive techniques like thermal ablation and foam ablation heals wounds faster. And I have seen that in the real modern day, I mean, in the clinical practice, that for small ulcers, you do a laser ablation or foam ablation, and sometimes when you remove the bandages after a week, the ulcers have healed. So it works wonders treating the underlying venous pathology.
Yeah, so here we have a limb with a chronic venous ulcer, quite a large ulcer. And Arun, I know you are quite fond of this treatment, so am I. Yeah,
this is kind of a clinic-based treatment modality, and these are some guided further this patients to undergo. Yeah, you can see the cannula is already in place, multiple cannulas. So these cannulas are inserted under some guidance. And this goes in two directions. So one thing is in the thigh, you can see one cannula, it's in the long this way. The other below knee, there are three cannulas, one is directed actually downwards as also. But doesn't matter. So what it really means is that what you want to get rid of the superficial veins by the chemical ablation. So, so here what we do is we make foam, we get the liquid scleroderm, that's STD, and we make one to four mixture that we make foam. So, and then we once cannulated, we keep the leg elevated, and then we drain the vein, so empty the vein, and then we inject the foam into the cannula, to the cannula. So that by doing so, so it actually increases the surface area of the chemical, and also it gets the maximum discharge.
Yeah. So yeah, this just shows the cannula in place and even pretty close to the ulcer, because the ulcer bed, there's been a reflux, which is probably due to perforators in and around the ulcer. They probably will be dealt with by this method. Nalaka, do you do this?
Yes. Okay, I must confess, I don't use foam as the primary modality unless the patient is very old. I generally leave foam alone. I mean, foam as the primary treatment for patients who are 75, 80 plus kind of thing. But I do use foam for definitely, like Prof said earlier, recurrence, because what you need to remember is, and what you need to tell the patient also is, whatever treatment you do for varicose veins, there's a fairly high chance of recurrence. And even 10, 15 years of follow-up, the patient will always recur, and the varicose veins recur, patient will always come back with pains. If they do have recurrences, yes, then definitely foam. There is also another place where you have actually previously treated your varicose, either with subligation or stripping or foam or endovenous laser ablation, and then sometimes you tend to miss mid-calf perforators, lower perforators, like Prof said, in the ulcer bed. Immediately underneath the ulcer, there will be a big perforator, and that is often missed, mainly because stripping also stops just below the knee. And even the thermal ablation stops in the upper one-third of the calf. So middle and lower part of the calf, generally, if there are big perforations, there are smaller ones, generally, once the proximal veins are treated, they do close up, but big ones sometimes tend to remain. That can give rise to recurrence of the ulcer. So In those instances, I use selective ultrasound-guided foam ablation.
Right, we'll move on. I think we've gone beyond an hour now. Something very important when dealing with chronic venous disease is elevation. Ranjika, are you a great fan of elevation?
Yeah, we always advise to keep sometimes I actually admit these patients to the ward so that they are in bed and the leg is elevated and it does wonders, takes off the edema, takes off the venous pressure and uh, and really helps wound healing. As we know, it's the ambulatory venous hypertension which causes it. However, when you just advise and send them home and ask them to keep the legs elevated, it doesn't really happen the way we want to. So it's a difficult thing to do with compliance, but it works beautifully. So when there is a patient with a lot of swelling, I would sometimes with a very oozing, ulcer which have been there for a long time, I admit them, keep them in bed with a lot of elevation, together with compression, it heals more.
Yeah, definitely. It's only for very resistant, difficult to manage ulcers in very swollen legs. When everything has failed, even compression has failed, we would admit and elevate. But otherwise, elevation is not the main method by which we control venous hypertension. It is compression. And Ranjika, Nalaka, would you like to just very briefly say how we apply compression or what we use to apply compression? And yeah.
Yeah, so generally in clinical, day-to-day clinical practice, what we use is cotton and crepe bandages. So multi-layers compression. So we use multiple layers. It is recommended to incorporate the calf muscle pump in your compression. So even though the ulcer is in the pre-tibial area or malleolar area, you need to actually compress higher above, starting from the proximal one-third of the calf downwards up to the midfoot area, just like this picture shows, incorporating the calf muscle pump. And you use multiple layers. So you use cotton, initially primary and secondary wound dressing on the ulcer, and then cotton and crepe, and then sometimes on top of that we even use elastoplast, like a fourth layer. So compression is that. Then you also have the socks, the different types of stockings, class 1, class 2 type of stockings. Class 3, class 4 stockings are also available, but very rarely used. Usually what we use is a class 2 stocking. This picture, what it shows, this brown color stocking is a class 2 stocking, which is the recommended one. Usually, once the ulcer heals, to minimize recurrences.
Yeah, so bandages when there is an ulcer, and very important to go include the calf muscle pump, because we see some people coming with bandages ending way below the calf muscle, and then compression, stockings long term to prevent manage edema and prevent ulcer recurrence. So I think we can go on and on. I mean, there's so many details on venous disease. We'll move on to the diabetic foot ulcer problem. And as we all know, diabetes, it's a vascular disease. And Ranjika, will you tell us very briefly, 2 lines, pathology, macro and micro?
Yeah, diabetic foot ulcer has mainly 3 problems. One is neuropathy which includes sensory neuropathy, autonomic neuropathy. Sensory neuropathy makes the foot numb and makes you more prone for injuries. Then autonomic neuropathy makes it dry, cracks, and again that predisposes you to infection. Then there is motor neuropathy, which causes wasting of small muscles and together with the glycosylation of tendons, it causes deformities. So these together, they cause the deformed foot with pressures at the wrong sides. It redistribution of pressures, which gives rise to callus. So that's neuropathy. Then you have a vasculopathy, which includes tibial arteries mostly, and also there is a microangiopathy, which with the endothelial dysfunction, which causes small vessels of the foot to get affected, but you should not get away. That's the main pathology. Main pathology is the tibial arteries getting occluded. Then you have also you have um, immunopathy, which is dysfunctional leukocytes or polymorphs, which again gives rise to infections. So, neuropathy, vasculopathy, immunopathy are the main areas which, together with all these, causes deformed foot, pressure sites, and all these together causes diabetic foot. And there is another entity which we have to entertain, which is the Charcot's foot, which again happens with the neuropathic foot, which is also part of the diabetic foot. So this is the pathophysiology of diabetic foot in summary.
Yeah. So basically, diabetes, what I wanted you to say what the vascular, it's a vascular disease, apart from the hyperglycemia and the metabolic problem, it's a vascular disease. The macro vascular disease is an occlusive atherosclerotic arterial disease. And the microangiopathy is non-occlusive and functional and involves the arterioles and the capillaries. And as Dr. Anjuka explained in detail, it results in easy wounding and faulty healing. And the problems are injury, ischemia, and immunity and infection, impaired immunity and infection. So going back to the wound healing process that we alluded to at the beginning, you have recurring minor injury from bacteria and physical trauma, maintaining maintaining inflammation, and there is sabotage of the proliferative phase, and the whole process is stuck right there, giving rise to what we call a non-healing or a chronic ulcer. So, Nalaka, you see this toe, very common presentation, people coming with nail problems, paronychia, and the GP has given amoxiclavulinic acid, the antibiotic for everything, and referred for the removal of the nail to you. The foot is not warm, but there is pain in the big toe. What are your thoughts, and what should you do? I mean, as a next step, not the detailed management.
The first thing
would you remove the nail?
No, definitely not. First thing I would do is check the pulses. I mean, like Prof said in one of the earliest, as we started the talk, we as vascular surgeons always recommend, and we do practically do also, anything in the foot, always check the pulse. So if the pulses are palpable, then half the battle is won. And after that, it's very easy. But if, on the other hand, if the pulses are not there, then you know there is going to be much more. Basically, what you see here is the tip of the iceberg. There is discharge there is blackness there. If you look at it closely, the distalmost part of the toe, I'm not talking about the wound itself, but even beyond that, slightly darker. So there's a lot of infection, and in the absence of a palpable pulse, there's also respiratory pulse. I will say respiration is in serious trouble. You need to really look at that much beyond just removing a nail. If you remove the nail, invariably that's going to end up with exactly what that picture shows.
I mean, that's what happened. Yeah, when a non-surgeon removed them. Surgeons don't do things like that. They check their pulses and refer. But very commonly, maybe a junior medical officer would remove the nail, and you start seeing necrosis, infection, and patient easily loses the big toe, if not the foot, if not the leg, because of a very common problem that we see. So How do you diagnose peripheral vascular disease? Here we are talking about chronic ischemia, chronic limb ischemia, peripheral vascular disease. We are not talking about acute limb ischemia. I think lots of even medical students, junior doctors, look for a cyanotic or a pale limb, cold limb, severe pain, paralysis, paresthesia. The 6 P's that everybody remembers is acute limb ischemia. It's not PVD. And if you look at the probability of healing in the y-axis and millimeters mercury, the blood flow, you can see the sigmoid curve. And yeah, if it's down here at the bottom of that is very severe ischemia, you will see the cold limb, the discoloration, and typical features of, you can see the ischemia. But in most of these instances, it's not obvious. Only the absence of pulses will tell us that there is arterial occlusive disease. The ischemia is not severe and often missed because of that. Here we see the cyanotic right foot, which is acutely ischemic, and absent pulses, it looks quite normal. So pulse checking skill is crucial. Arun, what would you do here? Another presentation, even in casualties now?
It is, so in the left foot is gangrenous. It looks like dry gangrene, and there's nothing to actually, not much, we have the infection, so there's no hurry to amputate this big toe, otherwise it's will go on and on. So this clearly, typically peripheral artery disease, having the ischemic toe.
Yeah, once again, the SHO surgery has removed the toe.
Then,
and you see what happens.
Then you can see the rest of things. The toes also become gangrenous. And because we're thinking that we removing this toe, which is gangrenous, is going to eliminate the sepsis and all, but we are causing another area, boundary of vulnerable area for the infections settle. So let's go on and on. It's the time of fully repeating low limb. So basic thing is about the getting the blood supply back. That's for revascularization, establishing this patient. Very important to check pulse, and then afterwards we go on revascularization procedures. There are things like angioplasty or bypass we can do. So this is the critical ischemia, and then getting things right.
Yeah, I mean, if the perfusion is good, you could remove the dead toe and get a primary anesthesia. As you can see, there's a missing here, implying a bypass operation and primary healing. So, chronic limb ischemia with a wound becomes a critically limb-threatening ischemic limb. And that's what happens in most instances with diabetes. Nalaka, common presentation?
Yeah, I mean, that's the heel areas. So probably
it's a huge wound.
Yeah, huge wound. Would have started out with as a neuropathic ulcer or neuropathic tropic ulcer in that heel area, but looks definitely ischemic. That's why the dark, pale areas, the necrotic area. So clinically, I mean, obviously you have to check the pulses and reconfirm, but it looks definitely neuroischemic type of ulcer, the combination of neuropathy and ischemia. That's even worse. Half the foot is already gone. You'll be lucky to save that leg if we intervene very fast.
Ranjika, why do you think this happens? These are still living people.
Yeah, I think it's because somebody starts debriding without checking the pulse and the perfusion. And it just multiple debridements and debridements without revascularization causes a foot like this. So I mean, now it's much less actually. Now the referrals are, we used to get these a lot few years ago. Now people are a bit more vigilant, and surgeons check pulses and they now people, a lot of dry gangrenes come with toes. I mean, this is like when nobody checks the pulse, debrides, and after so many debridements, they realize this, we are not winning this war, and then they think of the vascular surgeon.
Yeah, this is interesting. The infection and ischemia together there is synergy, the deadly combination. It's just not I plus I2, it's I square actually. And you can see evidence. It's not if you have non-healing versus infection and peripheral vascular disease. You can see that in the presence, infection alone doesn't, it's the infection with peripheral vascular disease which is causing more non-healing, right? Peripheral vascular disease alone doesn't really have much of an impact. Similarly, infection-related mortality. Once again, infection with peripheral vascular disease is what takes off compared to when there is no peripheral arterial disease. So the combination is what is really deadly. Aruna? Yeah, anything about how we could predict risk of lower extremity amputation and benefits of revascularization?
Yes. So there's a very nice scoring system now. This is called Wi-Fi scoring. So there we actually look at the wound severity, then the ischemia, and then the foot infection. So that's the standing for Wi-Fi. So scoring will given 1 to 3 depending on the wound and the ischemia and foot infection. So we can score it, and then we can predict the amputation risk in diabetes.
Yeah. Now, once we decide to revascularize, I think it's important now to highlight that we don't need imaging to diagnose peripheral vascular disease. You see lots of patients waiting for dates for angiography, duplex scans, without really coming for treatment because they're waiting for this diagnostic scan. We don't need a scan, do we? We do our scans anyway. Absent pulses, we should be referred for necessary imaging and intervention. Imaging determines how we plan the procedure. Tell us something about the different methods by which we get our images, Nalaka.
Yeah, absolutely. I agree with you wholeheartedly. Peripheral vascular disease or ischemia, chronic limb ischemia is a clinical diagnosis. Plain and simple. You don't need to do a Doppler or duplex scan to detect peripheral vascular disease and then send the patient to the vascular surgeon. If you have a non-healing ulcer and if you can't feel pulses, if there is no palpable pulse, that's your diagnosis and it stops there. The imaging is actually not diagnostic. Imaging is done as a planning method to assess what kind of revascularization the patient requires. Generally, to remember it easier, you are in 2 stages. So you get a patient with a suspected chronic limb ischemia, peripheral vascular disease, your diagnosis is clinical. Then the vascular surgeon takes over. Then the vascular surgeon will decide on the imaging technique, whether it's a CT scan, MRI, MRA, digital subtraction angiogram, or a simpler duplex, depending on what he or she, the vascular surgeon, is preparing to do in terms of revascularization. So the answer to your question, what you asked, the imaging techniques that we use, the bedside easy technique that we use nowadays is obviously duplex scan. The vast majority of our patients only have duplex scan done. We don't go for CT scan and angiogram is routinely, mainly because it's not freely accessible. Plus, most of these patients also have diabetes and chronic kidney disease, so that prevents them from having routine angiography. So duplex scan is fairly good and very informative, especially when done by someone who is familiar in doing duplex scan for arterial disease. When there is a doubt or when we need further information, yes, we do go for CT angiograms. The images you see here are CT angiograms. And with a proper CT angiogram and a vertical reconstruction, is what we have here, you can get a fairly good idea about the nature of the disease. The confounding factors obviously are the calcifications in the previous picture. So the CT angiogram doesn't differentiate between calcium and patent lumen. So in those instances, you have to go back to duplex anyway to see whether a suspicious area is actually patent or not on duplex. So very often it's a combination of CT angiogram and duplex scan, and the combination of those two together will give us the necessary information we need to decide what kind of angioplasty or what kind of bypass we are planning to do. DSA is the other method that is available, digital substruction angiogram. That's a direct arterial puncture, reserved for specific instances nowadays, because obviously it's more invasive, going directly into the arterial tree as opposed to a peripheral cannula that is required for CT angiogram. But obvious advantage of DSA is that it can also be therapeutic. So in the proper, if you plan it properly, you can do the diagnostic confirmatory imaging as well as in the same sitting do angioplasty and stenting and whatever you require in the same sitting. So you should have all this in your armamentarium. The mainstay is always going to be duplex. As I said earlier, the great majority of patients will be managed only on duplex scan. Second thing would be the CT angiogram. And very often CT angiogram images and the duplex images together will give you enough information about what to do. If you are thinking about a therapeutic intervention also, then you do a DSA, the digital substruction, where you can use it for imaging, diagnosis, as well as therapeutic angioplasty. MRA is the other one that is available, which we rarely ever use nowadays because the images are not as good as CT angiogram and very rarely used, I would say.
May I add a couple of information that the CT angios we do. CTs are good in terms when you can't feel a femoral pulse, because the duplex has limited role in there. Because if you want to diagnose the arterial disease, certainly we have to go by CT or MRA.
Yeah.
Because duplex is very limited in that. Because the bar shadows, you don't see the good feel by the duplex. The other thing is about CT is that there are calcification, particularly renal impairment and other diabetic patients, they get all calcifications. In that sense, sometimes you might miss for take it as positive with the contrast. And there's a false positive or being high in this situation. So you have to actually deduct the calcium and then get a proper view. Then only you can actually comment that there's an absent flow in that by CT scans.
Yeah. So how do we do the revascularization once there is necrosis to heal, a limb to be salvaged? We've identified where the occlusion is. We have either open bypass surgery with a vein or synthetic graft, or an endovascular procedure, which is primarily a balloon, whether they are drug-eluting or otherwise, to prevent restenosis with or without stents. And now we have atherectomies, lots of toys for endovascular revascularization. Ranjaka?
Yeah.
What is basically the principles by which you would pick on one of these procedures in your practice?
Yeah. Bypass procedures are mainly done for patients who are fit for surgery. And if you, from the Basil 1 trial, they said if you have 2 years of more life to live, if you predict the patient has more than 2 years to live, and generally fit patient, cardiac-wise stable, with a good inflow, as a pulsatile inflow, and a patent outflow, which is and a good vein graft, more than 2.5 millimeters diameter at least, a good vein graft, then you should always go for a bypass first. But if your patient is unfit, multiple comorbidities, extremes of age, 80 plus octogenarians, um, then provided they have a fairly okay renal function, then they are we go ahead and do an angioplasty. And also another task classification also is taken into account in certain instances where there are long occlusions, complete occlusions, long lesions. Then they are more likely that they will fail with angioplasty, and in those instances we do bypasses. So generally, a fit patient with a good graft, vein graft, we go for a bypass. An unfit patient with reasonable renal functions, we go for angioplasty. And I would like also to add now the Basel 2 and 3 studies have given results, and they actually did Basel 2 with mainly infragenicular, mostly tibial vessel disease, and angioplasties have given promising results, just like better than surgery. So I think I would stick to surgery for fit patients, and basically short stenosis, unfit patient, uh, the anatomic lesions which are amenable to angioplasties with a renal function, reasonable renal function for angioplasty.
Now, if you want to add anything?
Yeah, I mean, I tend to agree with Anju because if the patient is fit and he's got a good vein, and mind you, when you say duplex scan, we don't scan only the artery. We also look for a vein as a method of using as a conduit for the bypass. So if the patient is fit, cardiac wise, renal wise, expected to live at least 2 years or more, has a good vein, and if you're good at bypasses, I think, yeah, you're on. That's bypass will definitely give you a better overall result. But if you're thinking twice, patient is not fit, vein is not good, varicose or too thin, some patient has a renal dysfunction, other comorbidities, then angioplasty is definitely worthwhile pursuing. So most of the trials, I mean, the take-home message is what we just discussed. If you are fit enough, you can have a bypass. If you are not fit, angioplasty. And the Basel 3 latest result, what it showed is that irrespective of what type of balloon you use, whether it's drug-eluting or not, or whether it's bare metal stent with balloon or simple balloons, just simple angioplasty is enough. It gives equal results to the high flow drug-eluting balloons. So angioplasty is a definitely something that you should have in your armamentarium, and you need to decide what kind of patients to use. You also need to know something that we didn't discuss up to now is that there is always the chance of angioplasty failure and then having to go for salvage bypass, which is always going to be tough. And it's proven that trying to salvage and do a bypass and previously angioplasty patient is not straightforward, not as easy. So you need to put both these into account and put things in perspective. My personal opinion is yes, if the patient is fit and you have good vein and you're confident about the bypass first. If not, angioplasty.
Absolutely. I think we were brought up in a open surgical environment, and we get very reasonable results with bypass. So it's very surprising. All the trials have said what you said: fit patient, good vein, bypass, not balloon angioplasty. Whereas you see in the rest of the world, there's an angioplasty first approach. and surgery is surgery never happens because the problem with angioplasty is you really don't know whether it's working, and by the time you want to reassess, it's too late. You lost so much of the foot. It's not there's nothing much to salvage. So that's the danger. I find that in a bypass, we can monitor whether it's flowing or not. It's very difficult to do that with a balloon angioplasty. So I think our vein bypass first approach has stood us pretty well, and we use the angioplasty first only for those who are not really fit for surgery. And yeah. So now the next question is, now we commonly presented with large wounds. You wonder whether you can heal these even with good circulation, and whether the limb will be good enough for people to walk, ambulate. What's the point in having a leg if you don't stand on it or walk? What do you think, Arun?
Yeah. So here the wound is actually on the calcaneal area, so that's kind of a nasty place because the blood supply is very, very minimal here, and the infection is actually, you all know that the infection has gone up to the ankle joint also, so it's very, very crucial and critical. But having said that, if we get blood supply quite early before it actually infection goes inside, if we do the timely interventions, sometimes even we still salvage some kind of food, whereas so that patient can be beyond that. So it's always worth. There's another one. It's very, very ischemic and also necrotic. You can see just on top is actually the forefoot area. Severe ischemic, the toes are also varicose, blackish, and one is actually the heel. So, so that's don't know.
So, Ranjika, you healed most of these, right? That's
absolutely. Yeah.
With a good perfusion. That's what makes it worthwhile.
That's man.
The
midfoot amputation.
People are quite innovative. They manage to make shoes and walk on little stumps, which is very amazing. Moving on to the main one of the key problems in the absence of ischemia is also ulcers like this. Nalaka?
Yeah, in the absence of ischemia, earlier I said half the battle is won, but sometimes you don't really see that in clinical practice, because now this particular wound, I can see this man coming again and again and again with the same ulcer if you don't really advise him properly. And even if you advise him properly, the practicality of that advice is going to be also a question, because see, it's a neuropathic ulcer. So we are assuming that this patient pulses are palpable, no ischemia. This is a neuropathic ulcer, metatarsal end of the first bone. You can see lots of toe deformities. The second toe is also like a hammer toe. So next up, that will also get an ulcer. And the moment he starts walking, he's going to end up aggravating the bone. And this now the second picture shows severe ischemia. So the whole issue here, what I tell my patients when they come, is that they always come and say it's a small wound. And yes, it is a small wound, but underneath that there's a whole area which is infected or destroyed. And the second thing is, even if you actually heal this wound with, there is a thing called offloading. You remove the load in that area and prevent it from getting traumatized. You heal the wound, and then when you actually release the patient back to his whatever community, once he starts walking, it's always going to get traumatized again and the ulcer comes back. And you can always say, okay, we are diabetic shoes, everything. But I mean, in Sri Lanka, when I both know majority of our patients in the periphery, in the rural area, they walk barefoot. And inside the house, they don't wear shoes. So it's a big problem. But nevertheless, what we have to do as clinicians is identify it, try to do the best we can, prevent first picture from going into the second picture, basically, prevent infection. And
when there's infection, yeah, and when there's infection, yeah, the debridement.
Yeah, the debridement has to be radical. I always tell my trainees, you have to stay not 1 but 2, 3 steps ahead of the infection. If you try to do conservative debridements, it's never going to work. In diabetes, in diabetic foot infection, conservative debridements usually never work. So your debridement has to be quite aggressive, not too aggressive to destroy the entire foot, but always try to stay ahead of the infection. Then that's the best way of achieving success.
Yeah, antibiotics will not deal with necrotic material and pus. Yeah. Here is a woman, diabetes, of course, just 4 years, but she has infection. Doesn't know what happened, but there was a blister, ruptured, and this is not healing. Goes on, and the usual dressings and the antibiotics. Aruna, any thoughts?
Yeah, this is the pressure-bearing area, and also it's kind of a very prominent metatarsal heads. Yeah, I would presume that there's kind of an underlying because this has been going for long duration, so I think there will be underlying osteomyelitis here.
Yeah, probe the bone is very, very useful. Do you do that now all the time? Yeah, with a mosquito or a finger, if it's big enough. Yeah. So
also to show the patient that it's actually much deeper.
Yeah, that's true.
They come and say it's a very small wound, just to show them that it's actually going 1.5 to 2 inches deep.
Yeah. Yeah, I mean, if you can probe the bone, I think you need to deal with the bone. And I mean, yes, I don't do X-ray. I don't even waste time in X-ray. If it's going to the bone, you can clearly see the destruction of the metatarsophalangeal joint in that foot. Ranjita, how do you treat this?
So I would actually, when I probe, if I hit bone, metatarsal head, if I also don't take X-rays, I would just nibble it off, clear everything, necrotic bony parts inside. Generally, they are in pieces and clean it up. Maybe put a silver dressing on it and try and offload the ulcer.
Absolutely. Yeah. I mean, we don't treat this with antibiotics. We just need to get rid of bone. Of course, we don't know how much to get rid of. It's a blind, it's a guess. I hope that you removed all the dirty bone and the wound heals. So, just to give you an idea about bacteria on the wound, initially there is some contamination, and then the guys settle down, get attached to the surface, colonized, and then colonization increases and increases, critically colonized. That means it's not infected, it hasn't invaded, but almost there, interfering with wound healing, critically colonized. So, Nalaka, the balance, the bacterial balance, which determines which way things go. And we got all the factors that weigh on the host side and the bacterial side, which determines the direction in which the wound infection travels. Any idea about biofilm?
Yes.
I don't know.
Yes, we quite often see these biofilm formation by bacteria, particularly in chronic wounds. It looks like a very unhealthy graduation video. The appearance is that pale color, and then if you actually see clearly, so just the development of the bacterial developing secreting polysaccharide matrix, and then within that polysaccharide matrix, the bacteria is embedded, and it's like a bunker for the microorganisms, and it just prevents whatever the antibiotics we are going to do. It's very not of any use because they won't penetrate. So so that's important to get rid of the biofilm in any wound. So we can do the chemical or mechanical debridement. We can simply wipe it off on the surface of the wound, and or else we can do insert some chemicals to get rid of the biofilm. So it's something that we need to be aware of about.
Yeah. I mean, all chronic wounds have biofilm, and that's why you need to scrape it off. And I use a lot of acetic acid and even hypochlorite Milton solution. I think it helps to redden the wound, get rid of the macroscopic biofilm material. Ranjika?
Yep. So this is like a typical diabetic neuropathic foot, a rocker bottom feet, which has formed a callus, and callus has given rise to a ulcer because of the pressure which the callus puts on when they walk. So how I would manage this is just first cut it off. You can sometimes do it even with scissors, and that shows the X-ray shows the arches have collapsed and it has become a rocker bottom feet. The midfoot collapse is quite shown in this. So you can shave off the callus either by a scissor or even by a scalpel and try and offload this ulcer completely. The evidence say that you can use a total contact cast, but it's a bit cumbersome. We use a different way of offloading. I'm sure you might be having pictures of those. That's what we use for offloading, and for dressings we can use. I would use a gel because it looks quite moist. Maybe a silver dressing and try and offload it.
Yeah, it's amazing now, this patient, the amount of wound cap products, the culture reports that have been used, and so much antibiotics.
Yeah.
Representatively. None of that is relevant, as you said. You just need to get into the callus. This is a chart of foot, confirmed on X-ray findings as well. You can see the mid-tarsal bone fractures, joint dislocations, lytic areas, all pretty characteristic, typical of very advanced charcoal foot. And yeah, finally you need to offload. We'll come to the methods by which we offload. Nalaka?
Yeah, so the simplest method of offloading is a specialized dressing. I'm sure we might have some pictures later on. So we can actually use something like a ridge, an extra layer of ridge, just proximal to the wound, so that when the patient puts the foot down, the area of the ulcer will not bear any weight. That's the simplest method of doing it. Then there are the special footwear where you can actually get insole made, and the other things are the simpler methods of using a crutch or wheelchair. Basically, if you can ask the patient not to walk, not to bear weight, that's the easiest thing to do. But not the most practical thing to do, because I mean they do have to go to the toilet, they do have to get into a vehicle, they do have to walk even inside the house. So sometimes people don't have wheelchairs, even if they have wheelchairs, going into the toilet with the wheelchair is not easy. Most of the houses in Sri Lanka are not wheelchair friendly. So there are a lot of issues. We can say it, but it doesn't sometimes happen. So in those instances, at least use a crutch or to advise the patient that he shouldn't bear weight on it. You contact cast, the other thing that Ranju mentioned earlier, don't use that because it is cumbersome, and in a country like ours, a tropical country with this humidity, people don't tolerate total contact cast that long. And so we are down to using simple offloading techniques and specialized footwear. Yeah, these are some of the footwear you see. So you can offload any area of the foot, the forefoot, midfoot, or the hindfoot, or specialized a specific area of the ulcer, and then make sure that the weight is distributed to the rest of the foot.
Yeah, I mean, you need to take the weight off the pressure point. Total contact casts are very effective, but not practical. And all these devices, they're costly, but they are available even locally. Taking the weight off just below the patella, and you can reduce the weight by about a third on the foot, especially useful in a charcoal foot. Now, this is the most simple kind of common neuropathic ulcer. And just like what we did to the charcoal foot, we need to get rid of the callus and make sure that we don't go down to the bone here, so that you can just leave it if it's not going down to bone. How do we get rid of callus? I mean, we see junior doctors taking these patients, admitting them, going to theater, sometimes even anesthetizing these patients. I mean, they don't feel a thing. So all you need is a pair of scissors or a scalpel to remove. This can be done in your outpatient. In the outpatient. Clean it right down. And then the next thing is commonly used things that none of us really rely on, cutouts. All types of cutouts using foam, bits of foam. All the shoe makers producing soles. You see some of the physicians, they're very fond of getting cutouts. I just find that they really don't, they're not very effective. And the other thing is, all shoes, people have an option of not wearing them, and they don't. That's for sure. So, yeah, there are fancy shoes, taking the weight off certain areas of the foot. And this is what we do immediately when we see a wound that needs to be taken off, loaded, using the bandages and the gauze that we have. So patients don't have to go buying shoes, which will not happen. They can't remove this till the next dressing. I think we all use this with great success. Ranjika?
Yeah. Yeah, I think this is like a typical vascular dressing that we use. Probably all of us use this. It does the job when you tell the patient not to, if this is removed, that we will not see him again in the clinic, and they somehow really keep the dressing on. But you have to give the right kind of advice, because this is now there are a lot of areas which are unprotected. So sometimes our patients might just walk outside with this kind of dressings and suffer more injuries to the heel and the other areas. So you should always advise, this is not a protection, this is a reminder. I always say this is a reminder that you're not supposed to walk on this, and maybe use a wheelchair, crutches or something. But when you want to go to the toilet or something inside the house, maybe a couple of steps, use this. So that's the message that I give. But this works beautifully, and this is the only way that I have experienced that these ulcers heal. Otherwise, it's very difficult for us to heal these.
Yeah, so finally we have come to the end, and we got a kind of a flow chart of how we would deal with a diabetic foot infection, ulcer, and you can see the foot pulses are a very important part coming pretty high up, in addition to drain culture and antibiotics. And if there are no pulses, then you make an urgent referral. NDPI doesn't matter, and then that's what we do. And if the pulses are palpable, obviously you need to debride, offload, whichever way, and then local wound care. And if it's not healing, again, you need to look at things like compliance, reassess the vascular supply, reassess infection pressure, and there we go. So I think we tried to cover quite a huge area, two big areas within, I think we took almost 2 hours, but yeah, we try to cover things that would be useful to you, relevant to your practice. We didn't want to get too deep into revascularization methods, but just give you an overview of how the thinking goes. And you could answer any questions if there are burning questions, yeah, or comments, whatever. Have we missed out some big areas that would have been useful to you? Whatever.
Are there any questions?
You can unmute the mic and your mic and speak. When?
So there's one question on the chat.
Where the chat?
Yeah. On the lower panel, there's a chat icon, and on there, there's one question. Shall I read it out, sir?
Yes, please. Yes.
Yeah, sure.
When we get patients with ulcers who have both underlying venous insufficiency and occlusive arterial disease, should we first treat the arterial component followed by venous disease, or else should we treat both conditions simultaneously?
So, yeah, I mean, we discussed a similar case that Prof put out in the slide. So it all obviously depends on the degree of occlusive artery disease. Occlusive artery disease does definitely take priority over venous disease, but having said that, it also depends on the degree of occlusive artery disease. If there is an obvious venous ulcer and occlusive artery disease is not technically bad based on your clinical assessment and your ABPI assessment, then you can treat the venous ulcer and then just manage the occlusive artery disease medically with the anti-platelets, statins, and glycemic control and stopping smoking and so on. But on the other hand, if you feel that the venous disease is secondary or venous disease is not severe, or even if there is an ulcer, the ulcer has an ischemic component, then definitely the occlusive artery disease takes priority. So it's a very difficult question to answer and give a blanket answer. It depends on the clinical stage of the different diseases. But as a general rule, yes, occlusive artery disease takes priority.
I can add something. I recently had a patient. He was actually lined up for an angioplasty because his pulses weren't there, and but a typical small venous ulcer. Then the patient was really worried and came. Just by moderate compression, it completely healed. And because the ulcer characteristics were exactly like a venous ulcer, nothing suggestive of arterial insufficiency. So, but the pulses were absent, and the duplex scan showed some stenosis. So, So you have to go by, take the clinical picture and treat it. So what I told that patient was, I will try this. If this doesn't work and takes a long time, if it doesn't show any signs of healing, then we will go and do the angioplasty and improve the blood supply. So it's a difficult problem to treat, but as Nalaka said, always the peripheral arterial disease is the most severe form, not venous. But if the venous ulcer is a venous ulcer, then you can try a bit of compression and heal it without a revascularization. I've had many patients like that.
Yeah, and it's also one of the instances where you would adopt, you admit and elevate the foot, elevate and try to overcome the venous problem, and because you don't want to apply compression, and then if you can heal it without having to intervene on the arterial side, it might be an advantage. So once again, yeah, severity of the disease and how we can try to achieve healing with minimal intervention. There was a question on how to do there are several questions. One was SF ligation, how to decide on pressure. How to decide on the pressure, estimate the pressure in the compression. Yeah, we don't measure. There are pressure measuring sensors, which are not used in clinical practice. So we don't actually know how much pressure we apply. You don't need to apply a lot of pressure. What you need to apply is, we don't know, we don't measure it. But what you want is a stiff compression, not a lot of tight pressure. So don't worry about how much. It's usually never too tight. If the patient can tolerate and walk comfortably, you're okay. You just need firm compression, but stiff compression, not elastic tourniquet type of compression. That's why you have multiple layers, multiple components, giving the stiffness required to wrap the calf muscle pump. And when the muscles contract on a stiff compression, the venous outflow is demonstrably better. When we have an active venous ulcer, saphenofemoral incompetence should be postpone SF ligation due to risk of surgical infection. How do we time surgery? Yes, I mean, if you have a dirty venous ulcer, you don't want to do a clean operation, not too far away, particularly in the groin. I think that is the reason why, that is one of the benefits of endovenous therapy, where you have only needle punctures, no big wounds, no groin wounds to risk surgical infection spreading. So I think it's a good idea to avoid a groin dissection with a dirty wound around the ankle. It's better to then apply compression, heal it, and then do the SF ligation and stripping with a view to preventing or reducing the recurrence, as the evidence has shown. Even after a long period, several years, the recurrence rates were less. So delayed. But if you can do endovenous therapy, even foam sclerotherapy, it would be a beneficial thing to do to accelerate wounding. And if you haven't treated the trunk, you could do it once the ulcer heals. If you don't want to give foam sclerotherapy to the trunk, I'm talking of a setting where you don't have ultrasound and lasers, and foam is of course available anywhere. So it's ultrasound skills and the training to do it. How many days should we keep the compression stocking for before the next change? Very often, usually, I think we all do that. We keep it for a week. If the wound is very small and healing, I'll even keep it for 2 weeks. You know, you just wait for it to heal. It needs time and compression. So if the wound is big and exudating, then you need to change simply because it's too much wound discharge. So there is We don't, by the way, I think it's a good question because I see lots of patients getting wound dressings every other day. Totally unnecessary. You can, worst case scenario, you do it twice a week. 90-95% of the wounds can wait 1 week before the next dressing change.
It all depends on the size of the wound and the amount of discharge, amount of exudate. If it's a heavily exudating wound, yes, you might change it every third, every fourth day. So, like Prof said, maybe maximum twice a week. But if it's a fairly dry, small wound, just like he said, there are instances where we would do it once a week or once in 2 weeks. So that's perfectly acceptable.
There are two frequent dressing changes in dressing, unnecessary changes, will just damage the wound, retard healing, and it's extremely costly. You have to remember that people spend a lot of money on transport to their clinic, and additionally the dressings are also very expensive. So
only thing is though, you just to add to that, Prof. Only thing is though, you need to make that judgment, as I said, based on the amount of exudate.
Yeah.
Because there are instances when the exudate is very heavy. You would tell these patients to go and come back. They go home and they come back with an infection, or sometimes even the exudate itself attracts bugs and they come back with maggots and so on. So it can happen. So it all depends on the degree of exudate the patient has and the size of the wound. So the most frequent would be twice a week, going up to once in 2 weeks.
Basically, if you see wet, the surface,
oh yeah.
but smelly,
Yeah.
that's a time of change.
Someone has, Shehan Pera has asked, how do we treat skin changes following venous insufficiency to prevent skin fragility? Is there a place for steroid local application? Unless there is eczema and itching, I don't use steroids. But you know, since compression is applied, you know, there is no time, no way you can apply steroids on a regular basis. Not really. I mean, compression is the main. Compression is the method by which venous the stasis is dealt with, and if you do that, the itching will also settle. Most of the time, it's settled. How do we adjust the pressure dressing while doing strapping? Do we need to manage the pressure gradient or apply the same pressure from proximal to distal? Yes, I mean, when the diameter, the circumference increases, the pressure becomes less. You know, you can apply the same force. The pressure is greater in a narrow area because this is Laplace's law. So if you apply the same pressure, you will have more compression around the ankle. And as the calf gets larger, the pressure becomes less. So there is graduated compression automatically.
Just to add to that, you know, I won't mention trade names, but there are, when you use stockings, I've tried to tell this to my trainees also. When you try to use stocking, there are certain stockings which are the same diameter top to bottom. Like
Typically, yeah, typically.
Yeah, so you mentioned
no, I have no reservation. It's not meant for this.
Exactly. So when you use that kind of stocking, it doesn't do anything, because the thing is, if you look at it, if you think about it, it's the same diameter, same width, which means when you wear it, the thigh is going to be loose and the ankle area is going to be tighter, or rather the other way around. The thigh is going to be tighter, ankle area is going to be loose. It doesn't work. It has to be graduated, the compression stocking. It has to be like something called a shape. So it has to be the shape of your leg, wider at the top, narrow at the bottom, with higher pressures at the bottom area, lesser pressure at the top area, so that there is a gradient, pressure gradient, allowing flow to go in the natural direction.
The other thing is, I mean, I never ordered stockings above me, because for two reasons. One thing is you can't apply serious compression. As you go up in the thigh, it's the damage is too much. It's ineffective. Next thing is it just rolls down and sometimes cuts into the skin. Very uncomfortable. So it's uncomfortable, useless, and sometimes dangerous, and useless. So below knee, graduated compression stockings class 2 is, I think, what I would give everybody.
Above knee, up to the groin, I do use after surgery, after varicose vein ablation, so that your bracer vein ablated area keeps compressed post-operatively. But routinely for ulcer prevention and long-term care, below knee class 2 stockings is
No, I think the latest recommendation is class 3. I think one of the guidelines came up, or the for ulcer recurrences, class 3 is recommended, a higher pressure, provided there is pulse. There was, can't remember whether NICE or new guidelines, check on that. So they recommend higher class 3 compression to prevent ulcer recurrence. That's post-ulcer healing, yeah.
Yeah, post-healing. Sometimes I just keep them strapped for long periods.
Yeah. So that makes sense. So, so now what I do is I keep them strapped for a long time, and once the scar is mature, I put them on a class 3 compression. Below knee.
And
so we have gone 2 hours.
Yeah. And when you recur with your class 3 stocking, you know what happens, right? The guy is not wearing it.
Well, I mean, if you tell them adequately, and most people tolerate it.
Yeah.
Because that has become the commonest one that I use now, class 3.
Good. No more questions. So I think we've answered the questions, hopefully to their satisfaction, and there are no more questions. So probably everything. So let me thank Naraka, Ranjuka, and Aruna, and the college for support for having initiated this, and we are in the college, so it's quite a nice setup here with a big screen in front.
I miss being there.
Yeah. So yeah, and from here we go out for a drink, and
Anyway, it's nicely the cases are really covering everything.
So we'll sign off. Thank you.
Thank you.
Thank you very much.
Thank you very much for that wonderful discussion, sir. So this marks the end of the volume 4 of Surg Ahead. Next month, it's going to be on neurosurgery on 26th of June. Yeah. Right. Good night.
Thank you, Sandhini. Thank you very much. Okay. Thank you, sir.
Thank you.